Good morning, everyone. Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University School of Medicine's Serious Communicable Diseases program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an adult infectious diseases and critical care physician, the Director of Education and Outreach for Emory's Serious Communicable Diseases program, and your host for today. Please note this will be our last session before a short summer break. As always, before we begin, please know that we will be recording this session and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in an interactive and collaborative manner. And if you are interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. And if you'd like to ask a question during the session, please type it into the Q&A feature. We will do our best to answer questions in real time, and we'll discuss as many questions live as we are able. If we don't get to all those questions, we will post a recap addressing the topics on our website when the recording to this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC, and credit can be obtained for attendance upon completion of a survey at the end of the session. The presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. And here's today's agenda. As always, we will start with the Region 4 SITREP, followed by our case, didactic, and public health presentations with moderated Q&A to follow as time allows. And now it's my honor to introduce our guests for today. First, I'd like to welcome Dr. Henry Blumberg, Professor of Medicine and Infectious Diseases, Epidemiology, and Global Health here at Emory. Dr. Blumberg currently serves as the Director of Clinical and Translational Research Training Programs at Emory and for the Georgia Clinical and Translational Science Alliance. He has substantial global health research and research training experience, currently as the principal investigator for 2 Fogarty International Center Global Infectious Disease grants focused on tuberculosis research and training in Ethiopia and the country of Georgia. He's a leader in the field of tuberculosis. Next, I'd like to welcome Dr. Marco Schechter, Associate Professor of Medicine here at Emory and also in infectious diseases. Dr. Schechter currently serves as the Associate Medical Consultant for the Georgia Department of Public Health Tuberculosis Program and provides direct patient care to TB patients at the Fulton County Board of Health Respiratory Clinic. He's also involved in TB-related research here and in the broader state of Georgia, as well as the country of Georgia itself. And lastly, I'd like to welcome back a great colleague of mine, Dr. Amanda Feldpausch, Deputy State Epidemiologist and One Health Epidemiology Director at the Georgia Department of Public Health. Dr. Feldpausch oversees One Health activities in epidemiology in Georgia, including the Respiratory Diseases Epidemiology Unit, which includes TB epidemiology, in support of and collaboration with the Department of Public Health TB program. She also serves as co-lead for emerging health threat responses in epidemiology and the lead for the H5N1 response. Most notably, she has served with the DPH here in Georgia for over 12 years in a variety of roles encompassing the broad spectrum of epidemiology needs and focuses. Welcome to you all. Now, to place this session in context, the Emory University Serious Communicable Diseases program, in conjunction with the SRDRS, puts together special pathogens of concern situation reports for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channels, and listservs. And here is the current HHS Region 4 Special Pathogens SITREP. First, to Nigeria, where the Lassa fever virus outbreak has continued. In the latest official report from the Nigeria Center for Disease Control and Prevention on the 11th of May, there have been a total of 720 confirmed cases since the beginning of this year, down from 883 at the same time last year. But with 140 fatalities this year, there's a higher case fatality rate of 19.4%. Challenges continue to be due to late presentation of cases, high costs of treatment, poor awareness, and poor sanitation in the hardest hit areas. Next, since our last SITREP on the 26th of April, Uganda declared an end to the Ebola Sudan virus outbreak less than 3 months after outbreak confirmation. 14 cases, 12 confirmed, and 4 deaths were reported. This was the country's second Ebola outbreak in less than 3 years, and there was a truly fast, coordinated, and effective response. And to the east in India, where in the state of Karnataka, chiasson forest disease has been confirmed the cause of a third human death this year. Since the beginning of the year, there have been 151 confirmed cases with 3 deaths, and the most recent patient, who was 74 years old, developed, unfortunately, multi-system organ failure and died of cardiac arrest. And in Iraq, there have been several new confirmed cases of Crimean Congo hemorrhagic fever, or CCHF, in the past few weeks, with at least one fatal case and concerns for household transmission. This is the beginning of peak season for CCHF, which is transmitted by ticks, and thus far there have been 47 confirmed cases with 9 deaths in the country. And lastly, since our last SITREP last month, there have been no new domestic cases of H5N1, or highly pathogenic avian influenza, in humans that is, and it's unclear if this is due to a lack of actual transmission or lack of surveillance and diagnosis. At this time, plans that had been in place to develop an H5N1 vaccine have been canceled by the U.S. Department of Health and Human Services, and globally, Cambodia yesterday did report the country's fourth fatal case this year in an 11-year-old boy. Finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdp.emory.edu. And now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge base comfort level with the topic today. The first and the second should be up on your screen now. The first question is, how knowledgeable do you feel regarding the current state of TB in this country on a scale of not at all knowledgeable to completely knowledgeable? And the second, how confident do you feel regarding the current best practices surrounding clinical management of a patient with TB on a scale of not at all confident to completely confident? We'll give the audience a few minutes, or I should say several seconds, to respond to those. All right, and if we could please put some results back up on the screen for us. So for the first question, it looks like we have a pretty wide range from not at all knowledgeable to completely knowledgeable on the current state of tuberculosis in this country, which is great because it also means we have some opportunities for learning and education. And the same with the second question. It seems that as best practices have changed in terms of the clinical management, hopefully those in the audience will find this session quite useful. So with that, let's begin, and I'm going to turn it over to our first presenter, Dr. Marco Schechter. Actually, I'm going to pause there. I believe I just made a mistake. We are going to first start with Dr. Henry Blumberg. Apologies for that. But I do appreciate Dr. Schechter's readiness to jump in there with that curveball. So with that, Dr. Blumberg, we'll turn it over to you. I can see your presentation, so I'll be quiet.
Okay, great. Thank you. So I want to thanks for inviting me to be here today. I'll be presenting the case, which is a 61-year-old man with a history of stage 4 pulmonary sarcoidosis, who was on oxygen outside the hospital. And he was admitted to Grady Memorial Hospital after presenting with increased shortness of breath and dyspnea on exertion. And he also had symptoms of anorexia or decreased appetite. Because of his severe sarcoidosis, he had chronic shortness of breath, but he noted that his symptoms worsened for several days or a week or so prior to admission to the hospital. He had a chronic productive cough, and he was immunocompromised because of the sarcoidosis, because of the treatment. He was on chronic steroid therapy and was taking prednisone 20 milligrams daily. His past medical history was he was unstably housed. He was living in his car and was on chronic oxygen therapy, 2 to 3 liters of oxygen. As I mentioned, he has severe sarcoidosis, pulmonary sarcoidosis, and has a prior history of uveitis. He also had a prior history of deep venous thrombosis and heart failure with preserved ejection fraction. So on a physical exam, when he presented to the hospital, he was afebrile, but as I mentioned, and he had no history of fever or chills, but as I mentioned, he was on steroids. Vital signs were stable. On pulmonary exam, he had inspiratory rows or crackles in the lower half of the lung fields bilaterally. Laboratory studies, the chemistry panel was unremarkable. He had a normal creatinine, normal renal function. You can see his white blood cell count here. His hemoglobin was 12.3, and his platelet count was normal. He had HIV, hepatitis B, and hepatitis C serology done on admission. Those were all negative. And he also had a multiplex PCR done, and everything was negative. Influenza A and B, SARS-CoV-2 PCR was negative, and RSV PCR was negative. And on the left, you can see his baseline chest X-ray was very abnormal, a lot of fibrosis related to sarcoidosis. His admission chest X-ray on the right. Um, it's a little bit hard to interpret because the baseline X-ray was so abnormal, perhaps a little bit worse, but again, difficult to assess because the baseline is so abnormal. And then because of that, he had a CT scan done on admission, and he had evidence of upper lobe cystic changes seen here on the right, in the right lung. And he had a large left apical consolidation with a large area of cavitation, which you can see best on the sagittal section here on the left. He also had apical pleural thickening. Um, there was extensive nodularity within the right middle lobe and lingula, as well as the left lower lobe, compatible with endobronchial spread of infection. And he also was noted to have a subsegmental pulmonary embolism of the right lower lobe. And so the radiologist's impression of these findings was that they thought the patient had necrotizing pneumonia superimposed on a background of fibrosis with endobronchial spread of infection. And they're given the new cavitary consolidation with endobronchial spread, they thought TB or atypical mycobacteria were probably the most likely etiologies. And they also had some concerns about cancer as well. So the patient was admitted to the hospital, initially placed in a regular hospital room with a roommate, and the primary team taking care of the patient started him on therapy for bacterial pneumonia in an immunocompromised patient, and he was started on IV vancomycin plus cefepime plus azithromycin. After the CT results were back, he was started on heparin for treatment of a pulmonary embolus, and then infectious disease and pulmonary consults were obtained. When we saw him on the infectious disease service, the first thing we recommended is that given this cavitary lesion, that he needed to have TB ruled out, and so he was recommended he be moved to airborne infection isolation precautions. So he was moved to a single private room that was negative pressure, so basically put in respiratory isolation. And we suggested they obtain sputum from AFB smear and culture ×2, and sputum from bacterial culture, and he had blood cultures done on admission in the ER. And this slide shows the AFB smear. And the way these are graded is a quantitative. 0 would be smear negative, and then 1+ to 4+ is the way it's a semi-quantitative scale. But this patient really would be like 400+. As you can see, there's so many organisms that could be seen here on the AFB smear floor quant. So again, he had 4+ AFB smear positive, and at Grady, everybody who has a sputum submitted also has a TB PCR done, a gene expert, and that was positive for TB. So the TB PCR was positive and rifampin resistance was not detected. And again, he had the gene expert or the expert MTB RIF assay performed, and this is a real-time TB PCR. And the sensitivity is quite good on smear positive specimens in the US in the range of 97 to 99% sensitive. When the patients are smear negative but culture positive, the sensitivity is not quite as good, 60 to 75%. And the specificity of the test is quite good at 98 to 99%. And basically, this buffer is added to the sputum, and then some of the solution is put in this cartridge and it's put in the gene expert machine. And within 2 hours, you get two different real-time PCRs are run. One is to detect DNA, and tuberculosis DNA, which was detected, and then a second PCR for rifampin resistance, and rifampin resistance was not detected. So, sorry about that. So as far as the patient was started on treatment for tuberculosis with the so-called RIPE regimen, rifampin, isoniazid, pyrazinamide, and ethambutol. When he was clinically stable, he was discharged to what's been called the TB Motel. This is a housing program for unstably housed persons supported by Georgia DPH in collaboration with the American Lung Association Georgia. And then directly observed therapy was provided by the patient's local health department. So at Grady, the smears and cultures and TB PCRs are performed. And then Grady refers once an organism is grown, and an organism did grow pretty quickly, less than 2 weeks, because there's such a high burden of organisms, and it was identified as M. tuberculosis. It was then referred to the state lab for susceptibility testing. It took a little bit longer than usual because I think there's some technical issues, and the susceptibility testing had to be repeated by the state lab to ensure they had proper results. But it did come back isoniazid resistant rather. So once the susceptibilities came back, the regimen was updated, and basically levofloxacin was substituted in place of isoniazid because of resistance testing results. And the patient received 6 months of this new regimen. He was cured. His follow-up AFB smears and cultures became negative by 2 months of therapy. As far as guidelines, a little bit of self-promotion. We, in collaboration with the next speaker, Marco Schechter, and our colleague Susan Ray, we've developed through support of Georgia Department of Public Health, we've developed this app, the Georgia TB Reference Guide. This was a hard copy, and for the last few years, we've had an app, and it's available both for iPhone and Android versions, and we're in the process of updating it based on feedback from our users. In addition, earlier this year, updated guidelines on the treatment of drug susceptible and drug resistant TB were published, and this is a collaboration between several different professional societies and CDC. And so the key takeaways, TB is the leading cause of death due to infectious disease globally. The latest data from WHO were that there were estimated 10.8 million new cases in 2023 and 1.25 million deaths that year due to TB. In the United States, as cases are relatively low compared to low and middle income countries, a high clinical index of suspicion is needed. In the hospital, patients should be placed in airborne infection isolation precautions in a negative pressure room. If oftentimes it's recommended if there's a high index of suspicion and it's going to be a while till the diagnostic tests are back. Sometimes patients are treated empirically, especially if they're unstable. For diagnostic tests, what is generally recommended, at least in the US, and it may be different in other locations outside the US, are an AFB smear and culture, and then cultures positive drug susceptibility testing for at least first-line drugs, and then TB-PCR, or the expert MTB RIF platform, is very helpful in providing a rapid diagnosis and at least giving you information about rifampin susceptibility. Social services support is important, and it's in the state of Georgia available for unstably housed persons with TB, and that was highly beneficial to this individual. And it's important to ensure follow-up with the local county health department so directly observed therapy and follow-up can be provided.
All right, Dr. Blumberg, thank you so very much. We've had a couple questions come through the chat already, so I'm going to ask you to perhaps respond to them in the Q&A specific function. And with that, while that's going on, we're going to turn it over next to Dr. Marco Schechter for his presentation as well. And just as a reminder for the audience, we will be providing all of the resources that are discussed here in our post-session resources. So that TB reference application for mobile devices that Dr. Blumberg mentioned, we will provide the reference for that, as well as the IDSA guidelines. So with that, Dr. Schechter, I'll turn it over to you.
All right. Thanks. It's somewhat intimidating to present about TB after Henry Blumberg. For those who don't know, he was the lead author of the 2003 guidelines, which is still a great resource. I'm also a little under the weather, so if I make noises, bear with me. Anyways, this is going to be a very brief, very fast update of what's going on in TB in 2025. Here we go. This is what we're going to cover, and let's get through it. So like Henry alluded to, based on the WHO report 2024, TB is the most common cause of death from infectious disease globally, 1.25 million deaths. Leading cause of death among people living with HIV. One of the reasons I like TB as an infectious disease specialist is that people get better, and almost 80 million lives saved from TB treatment since the year 2000. And drug-resistant TB is still a problem globally, with only 2 in 5 people who have it treated. Very different situation in the US. This is 2024 provisional data, where we had 10,000 cases in the country. That is about 0.8 per 100,000 in US born people, but 15.5 per 100,000 non-US born people, and only about 100 MDR cases in 2023. All right, what are the diagnostic tests that we have available in the US? Well, chest x-ray, like Henry presented, is the first thing. What I want you guys to keep in mind is that a normal chest x-ray does not necessarily rule out TB. At Grady, for example, 7% of people who are HIV negative with culture-confirmed TB had a normal chest x-ray, and almost or a little more than a fifth of people living with HIV had a normal chest x-ray. So if you're thinking TB, if there are symptoms, a normal chest x-ray does not rule it out. And with HIV, the lower the T cell count, the more atypical radiological findings will be. So this is really a bottom line. Don't let a negative chest x-ray fool you. These are the sputum-based tests. The smear, you need lots of bacilli in there, 10,000 per ml. If you do 2 or 3, you have higher sensitivity. Better to collect 1 in the morning if you can. The culture is 10 bacilli per ml, much more sensitive, but there's a long turnaround time. It is an important test to obtain because that's how you're going to get a phenotypic susceptibility test. The gene expert, much more sensitive, as Henry alluded to, and you can get genotypic susceptibility for rifampin. We'll get into that. So this is the machine. If you know the name, you know what it does. It's the gene expert MTB RIF. The sensitivity, like Henry alluded to, is very high for smear positive, not so high for smear negative, and it's very specific. So a lot of times we have to put together a smear and an expert to make a decision of how to interpret it. If you have a positive expert and a positive smear, it's TB. If you have a positive expert and a negative smear, it's very likely TB. If both are negative, you cannot rule out TB. And if you have a negative expert with a positive smear, more likely than not, this is an NTM. How does this test work? So you have the RPOB gene, which is the gene that determines resistance to rifampin. You have this short region here that is the region of the resistant determining region. And the expert is essentially 5 probes that overlap and sequence this area. But you also have to keep in mind that you have mutations that can occur outside this 81 area, 81 base pairs area, that can also lead to rifampin resistance. So the test works. It says it's TB if at least 2 probes are positive, if it amplifies. And it says it's resistant if there's a delta between these probes. So let's say probes A, C, D, and E amplify, but probe B doesn't. It'll tell you that's there's MTB there and it's rifampin resistant. Of course, this test is not perfect, in part because there's, like, as I said, mutations outside it, but also silent mutations that cause it to be positive, Pro-B being the biggest culprit of that. So it's important to understand how the test works and review the report in detail with an expert in the subject. Sometimes you'll see discordance between molecular and phenotypic tests. So the expert says it's susceptible, and the phenotypic test says it's resistant. This is important to keep in mind because this happens when there is the so-called disputed mutations, which have been shown to have worse prognosis. So I want you guys to know if the phenotypic test says it's rifampin resistance, and the expert says it's susceptible, please consult an expert in the subject because this could still be rifampin resistant TB. How do we resolve these things in the US? The CDC has a service called the Molecular Detection of Drug Resistance that is generally arranged through your public health lab, and it does next generation sequencing of regions of interest. So this is an example here of a pre-XDR case where it shows a mutation on the RPOB, there's an INH mutation, there's a fluoroquinolone mutation. So this is a test that you should be obtaining in conjunction with your local public health experts if you're suspecting drug-resistant TB. This is very important. If you're thinking rifampin-resistant TB, please consult with your local TB program and/or your CDC Center of Excellence. If somebody can't tolerate rifampin for any reason, we call that virtual resistant. It should still be addressed as a rifampin resistance case, given rifampin is paramount to cure TB. Another thing germane to this group is the tests that we do a lot of times to look for latent TB, although that's not all they look for, the IGRAs and the TSTs. And I think a lot of people here are healthcare workers or deal with that. And this is a very important study from TBSC where they screened healthcare workers in the US, a low TB burden country, every 6 months for 2 years with a TST, a QFT, and a T-spot. And what you see here is that there are a lot of conversions, many more reversions, and there is no simultaneous conversion in all tests. So this is all to say that these tests are very imperfect. You need to interpret them with caution, and this calls into question the issue of screening healthcare workers as follow-ups. Of course, you need baseline testing for healthcare workers, but serial screening healthcare workers in the US may not be advisable. The other thing to keep in mind about these tests is that 20% of people with active TB, culture-confirmed active TB, will have a negative TST, QFT, or T-spot. So these tests do not rule out active TB. Very important. All right, that was fast. Now we're going to updates in TB treatment 2025. These are the guidelines that Henry has shared. These are the main updates. So drug-susceptible TB, we finally have a regimen that's four months. It's rifampicin, INH, Moxie plus PZA for 2 months. There has been a quest for a 4-month regimen for drug-susceptible TB for decades. We have one. This was done by ACTG, and no matter how much you break this down, the new 4-month regimen was non-inferior. However, I urge caution. Centers that have tried to implement this regimen in the US have had difficult results. This is from California. 81% of the patients had an AE. 50% stopped the treatment early due to an AE. So I'm not really sure. We're still trying to understand why we've had a hard time implementing this regimen in the US from a tolerance perspective. It could be that people are older, a different patient population, but it's certainly something to be aware of. In the state of Georgia, we are not using this regimen for 2 reasons. One, we can't get fluoroquinolone susceptibility routinely. You need that test. You need to know it's moxie susceptible to use it, and due to cost. So please don't use this regimen in Georgia right now. The other big update is the SHINE trial, which looked at shortening treatment to 4 months for non-severe TB in kids 3 months to 16 years old. It was non-inferior to 6 months of treatment. So rifampin INH, ethambutol PZA, the standard regimen, 4 months versus 6 months, it was non-inferior. And this is the guidance from IDSA. If you have a kid with clinically diagnosed TB, they don't need to have culture confirmed TB because the US is a low burden setting. We assume that most cases are from contacts that are drug susceptible. Of course, this does not apply if the index case is drug resistant. If they have just a peripheral lymph node, you can use this. If they have only one lobe, non-cavitary, you can use this regimen. So this is an important update for pediatric TB. Of course, please consult with a pediatric TB expert. Rifampin-resistant TB, we've had several really good trials in the last years. We've had the NIX and the ZNIX, which showed that BPAL has great regimens, so bedaquiline, protamidol linezolid, high cure rates for drug-resistant TB, for MDR TB. And then we have TB Practical, which tested various regimens, including BPAL plus moxifloxacin, also with great results. So now the guidelines recommend BPAL with moxifloxacin for rifampin-resistant fluoroquinolone-susceptible TB, and BPAL if there is fluoroquinolone resistance. I'm going to repeat this again. Please consult with local experts if you have rifampin-resistant TB or somebody cannot tolerate TB. All right, this was quick. We're going to another update on LTBI treatment, which has also been, thankfully, an area where a lot of things changed. So these are the CDC guidelines from the year 2000, where now the preferred regimens are 3-HP, 3 months of weekly INH or rifampicin, 4R, which is 4 months of rifampin, and 3HR, which are 3 months of daily INH and rifampin. INH alone for 6 or 9 months are alternative regimens. Why is that? That is because these rifamycin regimens, base regimens, are shorter. People complete them. There is less liver toxicity and better efficacy. One of the challenges with these regimens is DDIs, with rifampin in particular. And many experts would not use rifabutin in lieu of rifampin. But here in Georgia, that's something we do. And this is also recommended by NCCA. So that's just something to keep in mind as you're dealing with drug-drug interactions. And if you're going to use INH, 6 months is probably all right instead of 9. Other thing I say is that now that we're using rifampin-based regimens for LTBI, I think it's more important than ever to think active TB before just starting this. So if I have a patient with a normal X-ray but is coughing and losing weight, well, you need to think about that before just calling that LTBI. The sort of like, where is Waldo is this now 6-year-old clinical trial of 1 month of rifampicin and INH daily for people living with HIV. This is a large trial, and it's a trial that a lot of TB experts have trouble reconciling with, and I'll tell you why. 68% of the trial population had a negative TST and/or IGRA. They were living with HIV in a high burden TB country, and that's why they're eligible. Nonetheless, there is that concern from some people, including myself. And these participants had, for the most part, well-controlled HIV. So our DHHS guidelines do recommend this regimen. I am still very conflicted about it because a lot of these patients did not have, immunologic evidence of TB exposure. One update we have in the arena of LTBI treatment is what to do with people who are contacts to people with rifampin-resistant TB, MDR contacts. And we've had 2 big trials of levofloxacin given daily for 6 months, one for kids and one for adults. And the results of these trials on their own are not exactly impressive, but what has been done as a pre-planned analysis was a meta-analysis of these trials together. And putting this data together, you find a risk difference of 0.41 for levofloxacin compared to placebo. It was very well tolerated in kids, and there was lower completion rates in adults. So this is what we recommend nowadays for MDR contacts. One thing that I think a lot of people miss that's important to highlight is that LTBI in kids 5 or younger. So if you have an adult with TB and you have a kid in the household who's 5 or younger, that's something you have to evaluate right away. These kids are at higher risk of progressing to severe and fatal forms of TB. So really consult with public health. Think about window prophylaxis, which is starting them on LTBI treatment while immunologic tests to determine if LTBI is present or absent or pending. The other thing to keep in mind for evaluation of recent contacts is that most close contacts with TB will go to develop active TB in the first few months after exposure. So I think one of the things we kind of drop the ball a lot in public health is delays in evaluating close contacts to people with culture-confirmed pulmonary TB. So this, as I told Gavin, would be a really, really rapid review in 15 minutes. Somehow we did it. Since it's been only 14 minutes, I'm going to give one more update without a slide. This year, the NTCA updated its guidelines for community isolation, community being the key word, not for prisons, hospitals, shelters, and so goes on. Now, isolation is based on time on treatment and symptom improvement. We no longer wait for smear conversion after treatment initiation because it's been shown that the smear after treatment is started does not correlate with infectivity, while smear before treatment is started is certainly correlated with infectivity. So these are guidelines you're going to see out there, and it's very important to keep in mind that they're for community settings only. With that, I've hit 15 minutes and I'm going to stop.
Thank you so much, Dr. Schechter. That was fantastic, action-packed as well, and has already sparked some fantastic questions in the chat too. So I'm going to turn it over to Dr. Amanda Feldposch for a public health perspective. And I would just like to mention as well too, we have a mantra in infectious disease here that I actually learned from Dr. Susan Ray, who was already mentioned as a TB expert, and that is, if you are thinking something potentially might be tuberculosis, it's tuberculosis. And if you think it's not, then you need to get your eyes checked. So with that, I'll turn it over to Dr. Amanda Feldposch.
Thank you so much. So I'm going to just go over a few things with the public health aspect and mostly epidemiology. So I know you all have heard a couple of these numbers, the 10.8 million and the 1.25 million deaths in 2023. However, just to dig in a little bit further for that, in 2022, 8 countries accounted for more than 2/3 of globally reported TB cases. Those impacted most include Asian countries like India, Indonesia, China, and the Philippines. However, there may be a bias of reporting due to healthcare system and case reporting mechanisms that can cause some surveillance bias. However, this was also kind of briefly mentioned before, but I want to point out that we will talk more about the specifics of epidemiology and data available in the US in later slides. But a relevant factor here is when considering the global picture of TB and the US, non-US born persons are disproportionately represented in the TB cases in the US. So in the 2024 provisional TB data in the US, 76% of the just over 10,000 cases that were reported were in persons that were not born in the US. This was affected or also shown in the rates, which were mentioned before, with 15.5 per 100,000 non-US born persons compared with a rate of 0.8 per 100,000 population for US born. So in the US, again, we'll get into a little bit more of the data reported by CDC, but just showing some of this available data for Stop TB. We do have some 2024 provisional numbers already mentioned. But this just shows that you can see by country on the Stop TB website, which is a great reputable source. Also just mentioning the Sustainable Development Goals that were adopted by the United Nations in 2015 include ending the TB epidemic by 2030. So they have this Stop TB countdown. But getting into the unique challenges when we talk about TB data and what's available for decision makers like yourself and treating folks, is a lot of the data is going to be a little bit older. So we have reports that we'll talk about in a bit that are updated as of 2022. That's a lot of our contact tracing. A lot of our TB data, as you've heard, is from 2023. And really what this looks like is we have some challenges with the duration of treatment, as well as contact tracing and how long those things can take with TB. I've added a couple of things here like mpox. When you're talking about comparisons here, we can have complete information on many infectious conditions and their close contacts and the outcomes of those persons within a few months. With TB, we may need to follow persons for years. So in fact, we are still in Georgia providing some updates to CDC on case outcomes of cases identified 2 or 3 years ago because of the duration of treatment or the duration of follow-up that is required. So it's just something to keep in mind when considering TB data. So here we have some of the 2024 provisional data. The first note that I do want to make is that TB disease is nationally notifiable and reporting is mandated in all US states. LTBI reporting is optional. In Georgia, it is reported in children, or reportable, excuse me, in children under the age of 6 years old, but that may not be the same in every state. In the US, one of the points that is important is that TB case counts and rates in the US began increasing again in 2021 after 3 decades of consistent decline. We've also had some recent outbreaks. This is a little bit of the, again, available graphs here on the side. And just to zoom in from a previous slide as well, we're seeing similar trends to what you see here in Georgia. We did have a slight drop in cases in 2023 from the 2022 numbers to 260 to 246, but we have 253 included in this provisional 2024 data. Of note, 34 states, including Georgia and the District of Columbia, reported increases in TB case counts and rates from 2023 to 2024. However, the percentage increase in both case counts and rates, that was 8% and 6% from 2023 to 2024, were less than the increases which were seen from 2022 to 2023, which was 15% for both case counts and rates. The national goal for TB patients completing treatment within 12 months, if a treatment duration is less than or equal to 12 months, is 95%. We have not reached that goal in the US, but in 2021 or 93 to 2021, we have fallen short of that. And then we'll move on to the next one. So just looking a little bit more at the epidemiology, in 2024, TB rates increased among all age groups except for persons 65 years or older. That group does have some of the highest rates to begin with. One of the resources that we often hear people are not aware of is the aggregate reports for TB program evaluation. This is data that is available on the CDC website. I mentioned this earlier. The most recent report is from 2022. As you can see, it's summary data, and it's reported as of August 2024. There should be updated reports after that reporting period in 2025. But these reports are a little bit further back because it's based on contacts. So it's looking at those folks who were identified as a result of smear positive cases in those years. So you can see here in 2022, there were a little over 33,000 contacts that were eligible. Of those, 19.4% were diagnosed with latent TB infection. And I'm going to show a graph here that just kind of illustrates this visually. So this just shows that, 24,000 of those 33,500 were examined, 4,700 were diagnosed with LTBI, and then 3,500 or so started treatment, but only 2,800 completed treatment. So again, mentioning that we do have some outbreak situation going on. This occurred in Kansas. A health alert network message went out from the Kansas Department of Public Health on January 31st, 2025. At the time, there were 67 confirmed cases of TB disease and 79 latent tuberculosis infections that were reported. As of this past Friday, that is now 69 active cases and 97 latent infections. This graph that's down in the bottom right-hand corner, that is from January. So it shows the case numbers have slowed, but it does help to illustrate the extended nature of TB outbreak investigations, contact tracing, and treatment follow-up, and how long these investigations can go on. So the last thing that I have here is just regardless of where you practice, live, or work, it's been mentioned by our other presenters as well, your state should have local TB data, guidance, et cetera, and resources for you. Here are just a few states. I'm just took some screenshots of their pages. Anywhere that you practice, you should be able to find this. And as the other presenters have said, your public health partners are there to help. They're help to put you in touch with CDC colleagues or to point you in the right direction for guidance based on your particular patient that you're seeing. So if you're not in Georgia, just take a look at your websites. I'm sure they will have some great contact information. But in Georgia, we're happy to support and help out as best we can. And that's it. Thank you.
Thank you so much, Dr. Felposh. And a reminder to the audience as well, we will be providing those specific page resources that were just mentioned for ease of use. And I just want to say once again, thank you to all of our presenters. These are some fantastic presentations. We know there's a lot of information here. There's also a lot of topics within tuberculosis that could probably form several of their own lectures. But we have some great questions, so I'm going to ask our panelists to come back on screen for the last few minutes of time that we have to answer some of these questions. And Dr. Felposh, I'm going to actually start with you. I have a public health related question that's come through, and I guess several different formats. And this is related to something that Dr. Schechter mentioned in terms of community isolation with regards to the National Tuberculosis Coalition of America's guidelines that came out in 2024 and seemed to emphasize a more individualized approach toward isolation, for patients in the community. And there's questions about how that might impact the current public health response when we do identify these patients who may be close contacts or who may be positive. And I was wondering if you could speak to that a little bit.
Sure. And I'm actually going to ask for Dr. Bloomberg to weigh in on this as well.
Sure.
So one of the things I think is interesting about TB, I'm going to kind of give a little bit of background for Georgia that I think is interesting for providers. So we are really fortunate. TB is a unique disease or condition where in public health, we have epidemiology and then we have program. A lot of things like MPOX, we handle predominantly in epidemiology as far as case follow-up and guidance and things like that. But TB is so complicated that we really turn to our program staff for the guidance on isolation and otherwise, whereas we in epidemiology do a lot of the data collection to help inform those decisions. I know Dr. Bloomberg works closely with that group, so I would love if he would be willing to talk a little bit about this.
Sure, thanks. So I think the situation is different in the hospital versus in the community. In the hospital, we have a lot of immunocompromised patients, so we take a very conservative approach, and we basically keep patients in, airborne infection isolation precautions pretty much throughout their hospitalization, unless they're going to be there for a very prolonged time, which is unusual these days. As Marcos mentioned, once you start an effective regimen, the risk of the person being infectious goes down quite rapidly. So the greatest risk of transmission is before diagnosis and treatment with effective regimen. Once the patient's on an effective regimen, the risk of transmission goes down quite a bit. And, it may take a month or two until you get negative cultures, but the risk probably goes down within the first couple of weeks. I don't know, Marcos, if you have other comments on that.
Yeah, so the NTCA guidelines now, based on available data, most patients may be eligible to come off isolation in the community setting after 5 days of effective therapy. Now, isolation for TB in Georgia is decided by the local health department, right? This is very important. This is not a decision that most providers in this room would be making in most states. At this time, we have not updated the Georgia TB guidelines for this yet. We're actually in a process of reviewing each and every TB case, culture confirmed pulmonary TB case, with the health departments in real time to work on isolation. For instance, yesterday I got an email about a patient who, if they worked at a grocery store, would be fine. But it turned out they worked in a hospital in environmental services, right? So every case is a case. It's very nuanced.
Sincerely appreciate that and all those responses. And I think that's an important point here that we've seen really throughout all of your presentations is there's a lot of nuance to this. There's a lot of case-by-case discussion and really with multidisciplinary input from various agencies, even especially when someone is in the community. Okay, great. We're going to move to some other questions now. And a lot of this has to do with identification. So Dr. Schechter, I'm going to start with you to get your thoughts on harnessing the ability of like electronic medical records and identifying these patients. I was wondering if you could speak to that based on your experience at Grady, et cetera.
I I'm at a loss for that in terms of, so I guess if I just to rephrase the question, using, big data, sucking in EMR and doing some sort of analysis to figure out, predict who has TB. I don't have an answer to that. Sounds very interesting.
I think I mean, at Grady, we do have a policy for who needs to go in airborne infection isolation precautions. We have certain criteria, but it's not embedded into the EMR. And I think one of the problems is a lot of the symptoms are very non-specific, like a cough. Like there's so many different things that can give you a cough. So I think it's a little challenging to get something that would have a high, sensitivity and specificity. I mean, as it is, we put a lot more people into isolation than actually have TB because we don't really want to miss anybody.
Right, those are
It's a great question. It's a great question, but I don't think we're quite there yet.
absolutely. And I think also one of the challenges too, to just to add is it's important for our audience to remember that infections don't have to come from somewhere else. And, we focus a lot on travel, but as we're seeing in the United States as well, that may not always be one of one of the best things to think about. Those are great points. Appreciate that. One thing that we didn't really touch on too much is personal protective equipment for healthcare workers dealing with patients who have tuberculosis. And a lot of our audience members are often pre-hospital or EMS based. And so I'm wondering if either of you could speak to some guidance perhaps on things for them to watch out for or recommended personal protective equipment that they might think about. Dr. Schechter, why don't we start with you, and then I'll get Dr. Bloomberg and Dr.
Actually, I'm
Feldpausch's
gonna
thoughts.
pass it straight to Henry because he was a
Straight, perfect.
microbiologist in his prior life.
Perfect.
Yeah. So, the PPE you need is basically a respirator, N95 respirator, is what's, recommended. And, it's obviously a lot easier in the hospital when we isolate somebody. You just need the respirator, when you go into that room. You don't need to wear it, the entire time you're in the hospital. I think it's a little bit different if you're working as an EMT or something out in the field, but if you thought there was a really high risk or the patient could have tuberculosis, then you might, want to put on a N95 respirator. I think that the issue is the prevalence is, in the US of TB is relatively low. But if you were worried, you should put on a mask or a respirator.
Absolutely. Yes, Dr. Schechter, please.
I also think just to keep in mind, and Henry, chime in if you need to, TB usually requires a more prolonged exposure. It's not like you have a sniff of it and now you have TB. You're unlikely to get it in a quick EMS interaction, I think. I don't know if Henry has thoughts.
Yeah, no, I agree. I think that's a really good point, Marcos. And there have been studies that like CDC did on airplanes. When somebody turned out to be flying with active TB, not on treatment. And what they showed is kind of what Marcos is saying. Like, you had to be close, so the people at risk for getting infection, were like in the same row or within one or two rows, and the exposure had to be generally a couple of hours. If it was shorter, a short flight, it was not likely to happen. So it was on like longer flights or international flights or things like that. So I think Marcos's point is very good. A brief exposure, statistically is much less likely to lead to transmission than prolonged exposure.
And the only thing I was going to add is CDC at this point under the NIOSH section, they do still have information up about reducing risk in certain settings. So as Dr. Bloomberg said, they talk about the respirator, but also engineering controls and administrative controls that can be considered if you are concerned about this in your facility for some reason. If you, have a reason to believe you may be more likely to see a TB patient, or if you do have somebody you suspect and you want to look at some of that more detailed information, that is available online as well. And I can send that link.
And the other thing is, if you're concerned, the other thing is source control on the patient. You can put on just a regular surgical mask when transporting the patient. That would be something else that could be done.
Absolutely. Thank you all for those thoughts. And again, we will be providing a lot of these links and resources that have been mentioned. I also just wanted to emphasize too, something that someone commented on in our chat is that, it's great to be able to wear an N95 respirator and a mask, but one of the things that has fallen by the wayside is proper fit testing of these respirators. And we've seen this a lot with what's happened through COVID and exposure. So I just wanted to emphasize to our audience and thank the person for that comment that yes, fit testing is super important in these cases as well. We have a few more minutes here, and I just wanted to address something that has come up. I know we focused a lot on pulmonary tuberculosis for our session here, but there have been several questions regarding extrapulmonary tuberculosis. And I was wondering, Dr. Schechter, Dr. Blumberg, if either of you could speak to, potential needs for isolation in some of these cases. Of course, this is a very challenging topic to address in a short time, but are there any specific pearls that our audience should be aware of with regards to something like that? Dr. Schechter, I see you're off mute. We'll start with you.
Yeah, so I think not exactly what was asked, but in terms of extrapulmonary TB, I think as clinicians, the thing we need to think the most is meningeal TB, because that is an opportunity to save somebody's life. And if you're thinking meningeal TB, starting TB medication right away and steroids and consulting ID is very important. Of course, that is not contagious. I am not aware of airborne exposure, in general from extrapulmonary TB. It has to be pulmonary or laryngeal, which is the most contagious form we can think of. However, there are well-documented conversions exposures for people with soft tissue abscesses or other forms that go to the OR and get aerosolized that way. And that's very well described. So if you're thinking that somebody has a soft tissue abscess that could be from TB, when you take them to the operating room, you should certainly use appropriate precautions and even dressing changes. That has been documented as well.
The only other thing I would mention, I agree with Marcos. If the patient just has extrapulmonary TB, they're generally not infectious, but a significant proportion of the patients will have pulmonary plus extrapulmonary TB. So in those people with extrapulmonary TB, it's important to make sure they don't rule out pulmonary TB, because they may have both, and then in that case they could be infectious from the pulmonary component.
All right. Thank you all very much. Those are fantastic points. I think we're unfortunately going to have to stop there, but we will be addressing the questions and comments we did not get to next week. So thank you so much to our panelists and to our audience. Before we do close officially, I would like to again just pose an interactive question to our audience that should be up on your screen now after participating in this session. How confident do you now feel about the current best practices surrounding prevention management, infection prevention, and control with regards to a patient with TB? You should all be experts in that short amount of time. No, we don't expect that, but on a scale of not at all confident to completely confident, if the audience could please vote now. And while that is occurring, I just wanted to say thank you again to everyone, to our fantastic presenters, our technical team here at the SCDP ECHO, Yasmin Thornton, our outreach coordinator and leader extraordinaire. If we could please have the results of that poll up on the screen. And it looks like our panelists have done an excellent job. We have at least helped everyone get into somewhat or slightly confident territory here, which is fantastic. I know it'll take us a lot of time to digest some of these resources. Once again, thank you so much to additional members, Sharon Fernandez, Delny Schmeda, Allison Claybor. Thank you for feedback and further information, including continuing education credits and the recording. Please check the links here and on our website. We look forward to seeing you again soon. Thank you very much.